I'm Su-Chun. I'm from Taiwan. I'm currently working in Italy, Raffaele Hospital. And my research interest is optical coherence tomography and to use OCT to study neurodegeneration in neurodegenerative disease such as multiple sclerosis or Alzheimer's. Okay, and now I'm going to show you about my work recently. It's about EAE model in DA rats, and we use OCT and web to study that. Okay, so we induce EAE with MOG, 33 to 55 peptide on DA rats, and then we perform OCT and web in 4 different time points. And before we had work on the longer time point, and then we see something like at the later stage, the axonal loss seems to accelerate. So I'm really curious about what happened in the early stage. So in these studies, we performed the immunization on 10 DA rats, and we follow the EAE until only 21 DPI. We have the OCT and web at baseline and 7, 14, 21 DPI, and then we collect for histology. And very interestingly, we find that in 10 EAE rats, we have 5 of them develop motor symptoms, while 5 of them show no clinical symptoms at all. But 100% of the rats, we find out the delay of web. So if you look at my poster, you will see that the red line shows the animals with motor symptom, blue line the animal without the motor symptom. And for all of them, you can see they have a significant web delayed compared to the healthy group. And more interestingly, in the group with motor symptom, you see the web delay actually precedes the onset of motor symptoms. And on the bottom, you see the result of the quantification of OCT image. And I quantified the thickness for RNFL and the GCL-IPL, so it's related to like the axonal loss and the cell body loss. Interestingly, you see in the group with the motor symptom, which they have a severe web delay at 7 dpi, they show an edema of RNFL thickness. And then at 21 dpi, the edema resolved, and then the RNFL thickness remains the same with the healthy and the other group. On the other hand, the GCL-IPL, no matter in which group, it seems to start to reduce from the onset of the disease. So we see like there is no axonal loss, but we have a cell body loss. And then we move on the histology. If you look on this part of my poster, then you will see the histology. At this early stage, we find actually no demyelination and also no axonal loss in the optic nerve. But interestingly, we find like there is a very severe inflammation. We use EBA1 for it should be infiltration of it could be the microglia or macrophage. And then we also see a very strong reduction of ganglion cell count. So in this way, what we saw in the early phase, the web delay actually is not driven by demyelination. It's driven by inflammation. And also the histology also confirmed with OCT that we don't see axonal loss in this early stage, but we do see RGC loss. And this RGC loss probably is due to the inflammation. And then if you move to figure 3, you see I try to separate the eyes into 4 groups based on the timing of the onset of the optic neuritis detected by web delayed. So you see like you have the red line, which is the web delayed from 7 dpi, and then you have, I have the 4 different lines, they related to web delay on different time points. And if you can compare the result of, if you use this web grouping to see the result of OCT, you will find out that only the group that they have the web delay at 7 dpi shows the edema in RFL. But on the other hand, for all the group, we see a RGC loss, no matter when it started the optic neuritis. And the most interesting part is there were 4 eyes. They didn't show any web delay compared to the healthy cutoff. But even these eyes, we see that there is a loss, there is an atrophy of our GCL-IPL layer. So if you move to the other side, is the histology result based on the web grouping. We see the same thing, like we see RGC loss actually is quite similar in the 4 group. On the other hand, the inflammation is like stronger if your onset of optic neuritis is earlier. So what we can learn from here is actually when we follow up to a longer EAE result, then at the end you find out the axonal loss seems to accelerate because to explain this acceleration of the axonal loss, I find that it's because in the early time point, we have the first RGC loss driven by inflammation. This will cause further axonal loss. But then at the second relapse of the EAE on DA rats model, then in the second relapse, we see that demyelination will cause another axonal loss. So these combined together accelerate the disease course. So when we follow up on the later stage, we cannot explain this pathology only from the demyelination. We should also consider inflammation will also cause this axonal loss. So I'm hoping this, and this result is actually very similar to what we see in human, especially is the part that visual symptom comes ahead of motor symptom, because like 25% of MS patients, we know that optic neuritis is their first entry sign. So I hope this result can further translate to human to make us to understand even better like how the relationship of demyelination and the neurodegeneration in MS patient and how we can detect the neurodegeneration earlier to benefit like early diagnosis and early treatment. Thank you. Okay, this is my first time in the annual meeting of European Charcot Foundation, and during these 4 years, I do learn a lot of OCT. Before I did MRI research for 10 years in psychiatry disease, and I started to learn about neurology since I entered Italy and since start to learn OCT. But I find this is a very awesome clinical tool also. So my future plans is like I would like to keep working on OCT field and try to improve the quantification of OCT to make the image to show their best benefit for the patient, for diagnosis and for disease monitoring. And also keep working on neurology disease because I like it a lot. And I hope at the end I can even combine MRI and OCT together, since these are two of my patients together and patient together, and then to have bring some better understanding of the disease pathogenesis of multiple sclerosis. Yeah, thank you.